Thornton up here this morning.
Thank you, Angel. It's a pleasure for me to be here. I have a teenage son, so I need two of those. I need air purification and I need valet trash services. Hey, Lou. I see so many friends here this morning. My neighbors, Lita, Janice Ayers, and colleagues, Todd and Ronnie. It's really a pleasure for me to be here, and I appreciate the opportunity. Who wants to talk about COVID? I do not. I can tell you, I'm so happy to be somewhere. We're not going to talk about COVID today. What I do want to share with you, when I was asked, I thought, what are the things that I have spoken about over the last few years that really audiences enjoy talking about? So I want to cover three things, and they sequence together for you. The first one is, we are in a state that values business and values capitalism and free markets, and there's a lot of conversation, a lot of questions about whether the free market could fix healthcare, whether the government is too much in healthcare. And so I want to bring a set of thoughts for you on free markets that I have used when I speak to classes at Wofford and other colleges where I have been asked to lecture. And I think it'll be food for thought. Ask ourselves, is this really what we want? What would the free market do if we didn't have any kind of policy overlay from our government? The second thing is to talk about how we got here, as how this nation built this healthcare system that we have today. Ours doesn't look like most other countries' healthcare systems, and why is that? I'll tell you a little bit about it. And then I want to tell you about what we have reaped as a result of the system that we built in terms of our own health status. So that's the path that I'm going to take, and I would invite you to join in. If you have questions, please feel free to ask. So, Tom's got me set up here. Let's talk about free markets real quick. I want to ask the question, can the free market fix healthcare? As we think about, we obviously know there are a lot of problems in healthcare. There's a lot of good in the system, but there are problems as well. So what is the free market? Characteristics of a free market. You know, you've got the profit motive, minimal government intervention, competition, and then adaptability. So that's what we think about when we think about the free market. How does that play out? I want to ask you some questions. I want you to think about some questions, and I'm not going to try to answer them or let you jump in the interest of time, but let's ask these questions. Should there be any limit on the compensation of a professional football player? Yeah. Tom Brady made $40 million this past season. Is that offensive to anybody, or do we like the fact that he can bring that kind of value is reflected in his compensation? Corresponding question. Should there be any limit on the hourly rate for a nurse? In this country, during the COVID surge, the demand for nursing has been so great that there are many hospitals having to pay temporary staffing agencies $240 an hour for nurses. That equates to $500,000 a year, if you converted that to a salary. Is that too much? Is it enough? Is it what the marketplace has sorted out? That is the general policy conversation. There is scarcity and there is high demand. That is what the market is bringing. Should there be a limit? Sean Stinson asked me to come. Sean and I are good friends, and so I've got equal opportunity questions here. His comes first, mine comes second. But should there be a limit on how much profit a health insurance company can make? Should health insurers and their investors be rewarded financially when they deny coverage? Do we like that idea? That is a free market notion. Should there be a limit on how much profit a hospital can make? This is the one that Sean would like me to ask publicly. And should for-profit hospitals be able to reward their investors for using the least possible resources in the care of patients? That is a free market notion that don't waste money, we're optimizing profits. Should hospitals go out of business when their communities can't support them anymore? We've seen 3 or 4 hospitals go out of business in this state. Bamberg, Barnwell, Marlborough Park, up in the PD, some hospitals closed. The communities are not growing, they're not thriving. The payer mix, the combination of who is there and how they can pay for the patient's care is challenging, and those hospitals close. Is that okay? That is a market phenomenon when companies go out of business. If I go out and open a restaurant tomorrow and you don't like it, it's going to go out of business, right? That's what happens in a free market economy. Do we like that with hospitals? And is it okay that, like schools, hospitals reflect the demographics and the success of the communities in which they find themselves? Schools and hospitals, if you go to the very poor communities, they don't look the same as they do in Columbia. Should employers be rewarded financially for only hiring people who are healthy because they will cost less? It's an interesting question. I think most employers don't screen people out. They don't discriminate against people who have significant health challenges, but that is a market-based kind of approach to increasing profitability. Here's one. Should individuals have a right to smoke? I mean, our country has decided, yeah, you have a right to smoke. The corresponding question is, should smokers be entitled when they do that, when they voluntarily choose to do something that is adverse to their health? Should government and employers be required to pay for their care that comes with the decision that they made? Another similar question would be, should individuals have a right to wear or to ride motorcycles without a helmet? That every day, the first day of session at the State House, the motorcycle crowd comes to the State House and makes sure that Representative Calhoun and her colleagues do not impose a helmet mandate in the state. Okay, fair enough. Do you think it's fair then that when they have an accident, that the rest of us participate in the payment for the head injuries that they incur? Those are interesting questions. Should health insurers be permitted to put lifetime caps on babies who are born with congenital heart or congenital birth defects? Prior to Obamacare, that was the case. There was a lifetime cap on health insurance policies. And many young children who were born with birth defects, they would burn through that in the first year, and then for the rest of their lives, they were uninsurable. That meant the families of those children had to come out of pocket to cover their health care costs for the rest of their lives because they've already used their lifetime cap. Is that how we want things to work? So some of these things have changed. This is, as I said, these are slides I used with Wofford students who want to go into healthcare, and I tried to suggest to them, think about these issues because this is the system into which you're going to be working. Whatever part you come in, if you're a physician, a nurse, a health insurer, you're going to inherit these conversations, these questions. Now, let's transition. How did we get this system that is a blend of government and market? And when you peel back the history book pages and you go back and you look, we did not have our current healthcare system prior to the Second World War. That is the time when America's healthcare system came into being as we know it, okay? Why is that? Well, back in the 1930s, we had a global depression. There was very little money to be spent, and we didn't have a lot of technology or pharmacology or surgical technique, so there really wasn't a lot you could have spent your money on if you had it. In the 1920s, we discovered penicillin, and we put it to use on the battlefields of World War II. And that was a transformational step in the history of medicine. Now we could treat disease, keep people alive. So World War II begins to change things. We also saw the emergence of our system, which is an employer-sponsored health insurance model predominantly. It's not entirely. Many people have their insurance through the government, but compared to most nations in the world, we are much more employer-based, employer-sponsored than most countries. So why is that? Well, in the Second World War, we sent 5 million men overseas to fight in the war, and we left a lot of people out of the workforce. They were women, they were not normally in the workforce, and disabled men. We had to start building many different things for the war effort that we had not built before. Tanks, guns, planes, ships, ammunition, jeep, all the uniforms, everything you can imagine that it takes to prosecute a war, we opened plants to do that. We opened them quickly. And so we brought all kinds of people into the workforce, and there was a labor shortage. Now, in a labor shortage, this is a Chamber of Commerce group. If you can't find people to work at your prevailing wage, what is the normal response? Well, you offer more money for people to come work. We're watching that in healthcare right now. So what happened? Well, the whole country needed to get more people to work. So we started pushing saw upward pressure on wages, and the federal government said, oh, this is going to be a problem. We don't need runaway inflation in wartime. So we imposed wage controls. Now, I knew we had price controls. My dad fought in the war. I knew we had price controls on rubber and gasoline and silk and other things. I didn't realize until a few years ago we had wage controls. And what I'm saying is the federal government said nobody in this country gets a raise until we okay it. Now that is significant policy from the federal government, but our GIs, remember our GIs weren't getting raises, and so Americans said, look, if they're not getting raises, we're okay, we'll live with it. Now, what is the policy impact? Why is that important for this conversation? If you're an employer, you still have to compete. So you can't offer more wages, what are you gonna offer? Benefits. One of the benefits that had never been offered was health insurance. That became widely popularized in the Second World War. At the end of the war, everything was rocking and rolling in the United States. We did not have a bombed out infrastructure like Europe and Japan did. We had a very, the war wasn't fought here, so we had an intact country, and our factories were going like crazy. We just retooled them to make new consumer goods instead of wartime implements. So employers said, this is working, and we'll keep the health insurance in place. That's where we got our employer-sponsored health insurance. Now contrast that with most other developed nations in Europe and Asia. They had a different result. They did not have a functioning economy in Europe after the war because it was disrupted by the war. They had, the infrastructure was bombed out. So who was going to organize the healthcare system in Europe? The government had to do that. And who was the government of Europe? The Allied forces. So we had a hand. It's really interesting. We often say, wow, we can't believe those socialists in Europe went with socialized medicine. Well, we in fact had a hand in both systems. We formed the American system and we formed the European system because we were the Allied forces after the war. The circumstances were so different though, we didn't have to do much in the US because it had already worked itself out as a market solution. In Europe, we had to stand that up. So we went two different paths. Government-sponsored insurance in most of the European countries and employer-sponsored insurance in the US. So that's what we had. And it rocked along for 20 years from the 1940s to the 1960s. And in the 1960s, we introduced Medicare and Medicaid. Now, many of you know that I worked for Strom Thurmond when I was in college. And a lot of you didn't know him, but many of you did. And Strom had a hard time keeping these programs separate. He would always say, now, Medicare, is that for the old people or the poor people? You had to tell them, you're on Medicare. Right? So Senator Thurmond was there in the Senate. He voted. We adopted Medicare to cover people who were 65 and older until the end of their lives. Now, at the time we adopted that in 1964, the average life expectancy for a man was 67 and a half. So that's a 30-month insurance program we built. It's not 30 months anymore. Fortunately, we have much longer life expectancy, and the amount of technology and pharmacology that we have now is much greater than it was in 1960. So we tend to be short-sighted in our policy decisions. We solve immediate problems. We don't solve problems out on the horizon. So we built this program, and we didn't put age, inflation indexes and age indexes. So it's still 65 until the end of your life, and it's much more expensive now than it was in the 1960s. We also adopted Medicaid, and Medicaid covers generally women, children, and disabled men. And you have to be low income in addition. Now, why did we not cover men? You cannot, prior to Obamacare, you could not be a single man and be covered by Medicaid. Why is that? I always thought that was in the 60s. Congress was chauvinistic and figured you men need to get off your rear ends and work, right? That is not why it happened at all. When I went back and looked, in the 1960s, we still had a draft. Every able-bodied man had to serve. Once you served, you had VA benefits for life. We did not have a problem with uninsured men. They were all insured. It was women and children who weren't insured, and that's why we built a program to cover them. So the 1960s, you pick up a lot of women, children, and older retirees with these two programs. Now you've got most people covered by employers, some people covered by the government, and we're getting closer to covering everyone. In the 1980s, President Reagan signed a bill into law that rounded out our coverage philosophy in this country, and that was a law called the Emergency Medical Treatment and Labor Act. Now, all of us in healthcare understand what EMTALA is. That is the law that says any of you who want to go to the emergency room, you will go there, they will screen you, and they will stabilize your condition whether you can pay them or not. Now, this is just Thornton talking, but that is the law that I believe leads most people to believe there's some right to health care in America. I would conclude with that. If I can go to the emergency room and Todd has to take care of me, well, I don't care whether it's his obligation or my right, I know I get to go use it. So this is the law that said no one in America is going to go without care if they are in a crisis. Interesting that that was signed by Ronald Reagan. Remember that presidents are going to solve problems that their constituents want them to solve, and America was really seeing some things on the nightly news and on 60 Minutes that it did not like. People dying on the streets. Parkland Hospital in Dallas, Texas, which is where President Kennedy was taken after he was assassinated. That hospital had a lot of public criticism for the fact that they would not deliver babies to women who didn't have insurance. And so women would sit in the parking lot until they actually went into labor, and then they would be taken in. Now that is not the way we expect our healthcare system to work. And so those are the kinds of stories that caused the Congress and the President Reagan, to enact this law. So that's what we have. So now, most people are covered by employers, some people are covered by the government, and everybody else can go to the emergency room. That is the way our nation built our healthcare coverage model. It doesn't work perfectly, but at least you know how we got there. So, in 2006, we expanded Medicare again. And it's really interesting, there's a lot of criticism for the fact we expanded healthcare coverage in Obamacare, but we had just done it 4 years before for Medicare, and that was the prescription drug benefit, Medicare Part D. Interestingly, Obamacare cost a lot of money, but this cost about 75% as much as Obamacare, so it wasn't like it was free, just the politics at the time were different. And you saw healthcare reform, that was a very acrimonious debate, and it continues to be debated in a lot of circles, although we're further and further out from it. We don't hear as much about that. Maybe that's one good thing COVID did for us, take the conversation in a different direction. But, so let me summarize and say, what was our system built to do in America? It was built to do these things. If we followed what I just said, it was built to recruit workers in the era of wage controls. That's World War II. It was built to provide health insurance to retirees from age 65 until the end of their lives. That was Medicare. Cover the uninsured, the remaining uninsured, that was Medicaid. And then anybody who didn't fall under those could go to the emergency room. That's what we built our system to do. Now, what is it not built to do? It was not built to encourage healthy behaviors or manage chronic diseases or keep costs down. That's not why we built it. I like to say, when I hear commentators or elected officials say our healthcare system is broken, I agree that we need to fix it. I do not agree it is broken. I believe it does exactly what it was built to do. It was built to address acute illness without regard to cost. And it's still good at that. We have an excellent healthcare system. But it is not cost sensitive, and it is not about managing chronic disease. It is about addressing acute problems when they arise. So, this is what we were not building it to do, and yet this is what we wish it would do. And that's why we have to change it, but it's hard. So let me tell you what happens as a result of this system. So in 1985, this was CDC data, I think, yeah. They began collecting data about obesity in the United States. And the white states here are states for which there was no data. The blue states are states in which there was obesity. You're going to see the obesity percentages. Now, obesity is defined as a body mass index of greater than or equal to 30. So just out of full disclosure, we're not talking about morbid obesity. My body mass index, unfortunately, is up in the high 20s, so we're not talking about there are a lot of people in this country who would be on this scale. In 1985, the light blue states had fewer than 10% of the population obese, and the darker blue had 10 to 14%. All right, you follow what we're looking at here? 10% or less is the light blue, 10 to 14 is the dark blue. So I'm going to run through these to 2010, and you're going to see how obesity has changed in this country. All right, this is 85, 86, 87, 88, 89, 90, 91. We had to add a new color because now we have states where it's 15% or greater that's obese. 92, 93, 94. There's 94, 95, 96, 97. We added a new color. Now we've got states that are greater than 20%. 98, 99, 2000, 2001. We added a new color. I'm on some state of Mississippi. 2002, 3, 4. 2005, we added a new color. Again, some of these states down here now are greater than 30% in the darkest states. 2006, 7, 8, 9, and 10. The blue states are gone. Every state has at least 20% of its population obese, and a lot of them have greater than 30% obese. So you can see how this has changed. Now, do we in healthcare, are we concerned about the cost of healthcare? Absolutely. But it is not fair, in my view, I'm not speaking for the hospitals, I'm speaking for policy in healthcare. It is not fair to conclude the only contributing factor is what hospitals and doctors and others charge. We have to own the fact that we are a less healthy population and we need a lot more healthcare. We're consuming a lot more healthcare than we used to. So that is a driver of how much healthcare costs. So we've put ourselves in a box. And this is how I try to explain it to policy classes and others. Our assumption in this country is if a physician orders something and says it's medically necessary, we should cover it. That's what all of us want. If we have needs and there's a condition, we want the doctor, if the doctor says it, we want our insurance company to pay it. That is how we've constructed the system. The problem is we can't afford to do that for everybody, so our public policy debate is about who should have that kind of insurance. And not everybody in this country has it. That is not the way most countries have solved this problem. In the United States, we cover everything, we just don't cover everybody. And in all the other developed nations in the world, they cover everybody, they just don't cover everything. Does that make sense? That is how, if you want to simply understand the American healthcare system, now you understand how we got here. We went through the Second World War, through a number of policy changes, solving problems that were right in front of us, and we've cobbled together a health coverage framework that doesn't work perfectly, but we have it and that's what it is. And we don't choose to cover everybody. We want really good coverage for anybody we give it to, but we're not going to give it to everybody. So that is the American solution to how to deal with this. But make no mistake, every nation that's in the developed world struggles with healthcare. Do you spend your money covering everybody, or do you cover a lot of things, or how do you do that? I'll tell you, from my own preference, I really like what Australia does with their healthcare system. They recognize in our country we have a hybrid. We have part government and part commercial, private insurance, Blue Cross, United, Aetna. I don't personally think we're going to get rid of either side of that hybrid. That's, thinking about politics, it's very hard to imagine we will no longer have government coverage. It's also hard to imagine we will never have private insurance. But in Australia, they do it differently. They stack their coverages. They don't have one or the other. Most people have both. The government program, and they call it Medicare, like we do, it covers every person who is in the country legally, including you if you visit Australia. But it only covers certain things. They will provide a doctor and a hospital for you, and they'll provide you emergency coverage. They do not give you branded drugs. They do not give you choice of physician or hospital. But you get basic care. If you want more than that, you buy insurance on top of that. So most people buy insurance to work their way up into the choice and the kind of coverages they want. So We don't do it the same way other countries do it. I do think that if we didn't have such difficult politics, there are better models for how we could solve some of the problems that we face. But I hope this gives you an idea of the choices we've made as a nation and the choices other nations make. All nations face the scarcity of resources. What concerns me is we want continued advances. We want Lou to keep discovering new ways of treating diseases. We want physicians to keep developing innovations. It's going to get more expensive, but we want to invest more in our health. The problem is, what does that do to this conversation? It makes us feel like we can't cover as many people as we do now, or otherwise we have to use too much of our GDP to healthcare. So we have a lot of challenges ahead of us. I think we really need to get more realistic about conversations. It's very easy to throw around the rationing word, but the truth of it is all of us make decisions every day about which things do we value, which things do we want to do, and which things do we not. I'm not advocating for rationing. I'm advocating for a more sensible conversation about how we manage some of these. So for example, there are insurance models now in this country being tested that would say, if you're having back pain, if you will go and try physical therapy for 6 weeks before you go to get your MRI and your surgery, the insurance company will pay 100% of all that out of pocket. You have no out of pocket. If you want to go straight to the MRI and surgery, you cover half of that yourself. We'll pay for it. I mean, you're insured either way. You have freedom of choice. But if you will take the more conservative, less expensive course, we'll insulate you from any financial cost there, just to try and get people to think twice before they go right to the most expensive services. So there are a lot of ways we could massage this. It's a slow process, but it's worth spending time on it because healthcare is a challenge for all of us. So let me pause or stop there and see if you have any questions, or if you want to talk about COVID, I'm happy to do that. Yes, sir.
Thornton, you said that our model is not covering everybody, but as you went through, you showed how we increased that group of people we do cover. Who are the people that, after Obamacare, are not covered still in the U.S.?
By and large, they are people who work full-time but do not work for an employer. They make too much money. They may make $15,000 a year, a single person, but they make too much money to be on Medicaid. Their employer does not offer them insurance, and they cannot afford to buy the commercial insurance. So they're kind of caught in this gap. They make too much to be on government assistance, but they don't make enough to buy insurance. So you all are aware, insurance is expensive, and so for an individual to buy a policy, it might be, $8,000, $9,000 a year. That's a lot of money for somebody who is making $25,000 a year. So, yes, sir.
But for most folks who make under $60,000 a year, you're eligible for a advanced premium tax credit or something of that nature, where the government essentially gives you a grant to pay for the premium for health insurance. So doesn't that come into play?
Yeah, not all states implement it the same way, but you raise a fair point. When we look at the number of uninsured people in South Carolina, half of the people in the state who are uninsured are eligible for insurance. They just don't go and enroll. So they either could buy it through the marketplace or they could enroll in Medicaid. So when we look at those numbers, part of our job should be to go out and find them and help them with the steps to enroll. And you all can do that if you have employees that you know, family members or friends who could be eligible and haven't taken advantage of it. The other half is people who are not eligible, and we naturally would advocate that they be covered some way. Yes, sir.
2 points. Jonathan, you mentioned the ACA.
Yes, sir.
ACA is based on income, not assets. You possibly could have $1 million portfolio and qualify for ACA because it's not based on assets. And number 2, it's just concerning to me how the dental industry, the dentists and everything, works so efficient and well without government involved. If the dentist can do it, I think doctors can do it.
Well, that's an interesting question. The 2 points he made were that under the Affordable Care Act, there are there are no asset tests, only income tests, and so you can have an asset portfolio but low income and qualify. The other question is about dentists, and I have a slide in here that sometimes I use about dentistry. Dentists are very efficient, and they, you make the case that, you know, why couldn't doctors be more like dentists? The difference is that we in this country have not made the policy decision that dentistry is an essential health service, and it's available to people even if they don't have insurance. So healthcare is, medical care is, and so most dentists that I know are carefully control the number of uninsured patients they take care of. So there are a lot of people, and there's a larger health question about whether we should be trying to do more oral health care for everybody, because it is essentially can often be a gateway problem to other medical conditions. If your teeth are unhealthy, your mouth is unhealthy, then your heart can be affected and a lot of other things. So great points. Yes, sir? Did you have back in the back? Yes, sir.
In 2019, the previous administration came down with an executive order regarding hospital price transparency. Has anything come of that, or do you have any thoughts on how that would affect our modern healthcare system?
That's a great question. The hospital price transparency rules. The healthcare industry, the hospital industry feels very strongly that it is appropriate for us to give transparent information on pricing to patients. But the way the federal government did it is not necessarily, we think, well crafted to help consumers. So let me just say, about 10 or 15 years ago, the hospitals in South Carolina, through the association, decided we're going to put our prices out on the website so you can see them and you can compare them. That is on our website. It's called Hospital Compare. Well, it's not Hospital Compare is the federal price point. But if you go to the South Carolina Hospital Association's website, you can see and compare prices. What the federal government has said is hospitals have to publish a list of 300 of their most used services and the insurance rates that are paid for them. That is useful information, but a lot of the things in there are broken down into components, and if you went to the hospital, your care would not exactly match up with what's on that list, and so you don't know which of these things your doctor is going to say you need. Maybe for a knee replacement, you might be able to look at that price and say, okay, I can count on that, but a person who has a more complex medical condition is going to have a variety of things that have to take place, and it's very hard for a layperson to look at that and say, I know what my cost is going to be. On top of that, the more important question is, what is your out-of-pocket cost going to be? And no hospital can tell you that without reference to your insurance policy and so forth. So we're going to comply with the federal law. We're concerned it's not as useful. Now, this is not a hospital association position. This is just Thornton thinking. But I think it's more useful for consumers if they can go to a hospital or a physician and say, I want a good faith estimate, and you can't come in more than 10% higher than that, just like you would at an auto shop or somewhere else. Well, now that puts the burden on the hospital. If they want to give you a really big number, great. You go down the street, somebody else gives you a more realistic number, they start losing business. It forces them to give you a carefully considered price, and then you can rely on it. They can't come back and say, well, something happened, there's a lot. Now, is that a challenge for hospitals? Yes. But I think that's more useful to a consumer than this long list of things, and you don't know what your condition is going to look like and which one is going to correspond to you. So we're going to comply with it. I just don't know if it's really going to help the problem like it's intended to. Yes, sir, in the back.
The current cost of living across the country is $15,000, or bar of $15,000, a reasonable bar to say you qualify for Medicaid, and has there been any thought to raising that? I mean, very few people make less than $15,000.
Let me make sure I understand the question. Has there been any thought to raising the eligibility thresholds for Medicaid?
Yes.
Yes, and that's what the Affordable Care Act did. And you know, I think what's fair to recognize is, remember, we have a hybrid system. We have commercial and private insurance and government insurance. The Affordable Care Act moved both forward. A lot more people were covered by commercial insurance, and more people were going to be covered by Medicaid to close that gap with the uninsured. There has been conversation about that, and It's tempting to think that Congress is just trying to give away money when they try to increase the eligibility threshold. But in fact, the cost of insurance is well beyond the ability of most low-income people to buy it. So you have to make a pretty good bit of money before you're going to spend, before you're able to buy commercial and health insurance as an individual. So they do think about it. A lot of states have expanded their Medicaid programs to allow that to go up to 138% of the federal poverty level. We're one of the states, as you know, that did not take advantage of that, so it's still a little bit lower. Lou, I'll ask my friend Lou's questions, and then I'll get back to Angela.
Why don't you tell everybody what the Hospital Association does to help all the hospitals across South Carolina? I think it's impressive what you're doing as an association to help all the hospitals.
Thanks, Lou. So she asked the question, what do we do as a hospital association? So we were founded in 1921. We just celebrated our 100th birthday. We were founded to give them a voice in government so that they didn't have to send someone every day to the State House or the regulatory agencies, and we certainly do that in South Carolina and at Congress for the hospitals of our state. And then we have a board, much like this Chamber's board, that gets together and sets policy and decides what is important, where are our challenges. We have also spent a lot of time in the last 15 years trying to help hospitals improve the way they deliver care. And that is not because we are resident experts in medicine. It is because we are a place they can convene and compare the things that are challenges and the solutions they found. And as a result of that work in quality and safety, South Carolina has really become a national leader in the care that's provided. For example, we talked about heart attack care. This is Heart Awareness Month. This state rebuilt our STEMI heart attack care system about 15 years ago, and it does not matter anymore where you are when you have a heart attack. We have a system that will get you the right care within the time frames that we need you to. So the target, if you're having a heart attack, is you want to get from the door of the hospital to completion of the balloon procedure to open your blocked vessel within 90 minutes. When we started our work, we were at about 93 minutes, which was close. We rebuilt and retooled all of the EMS and emergency and cardiology systems in the state, and we dropped that to about 46 minutes statewide. So South Carolinians are much better off in heart care because of the collaboration of this community of hospitals. So Lou, thanks for letting me give that little plug. And we are working really hard with the life sciences companies in the state, like Nephron, to try and bring more innovation to the patient's bedside as fast as we can. So it's an exciting time. I really appreciate you having me here. And Angela, I'll give it back to you.